Antimicrobial prophylaxis. Clinical scenario. A patient with a history of recurrent urinary tract infections, UTIs. Recommended medication: trimethoprim sulfamethoxazole, TMPSMX. Question 1. A 28-year-old woman presents to her primary care physician for follow-up. She has experienced 4 episodes of uncomplicated urinary tract infections in the past year, all treated successfully with antibiotics. She is currently asymptomatic. What is the most appropriate next step in management? A. Begin daily ciprofloxacin. B. Recommend cranberry juice. C. Start prophylactic TMPSMX. D. Start prophylactic nitrofurantoin. E. Perform cystoscopy. Correct answer, C. Start prophylactic TMPSMX. Explanation. For patients with recurrent uncomplicated UTIs, low-dose TMPSMX, example 1 tablet daily or after intercourse, is a well-established and effective antimicrobial prophylaxis. Why not the others? A. Ciprofloxacin, not first line for prophylaxis due to higher risk of resistance and side effects. B. Cranberry juice, may help prevent UTIs, but evidence is weak and it is not as effective as antibiotics. D. Nitrofurantoin, acceptable alternative, but TMPSMX is more commonly used and less contraindicated. E. Cystoscopy, not indicated unless there are complicated or structural abnormalities suspected. Question 2. A 35-year-old woman with a known history of recurrent urinary tract infections is prescribed prophylactic TMPSMX. After 1 month of therapy, she presents with a new onset of fatigue and pallor. Lab results reveal low hemoglobin, elevated indirect bilirubin, and increased reticulocyte count. What is the most likely explanation? A. Iron deficiency anemia. B. Thalassemia minor. C. Hemolytic anemia due to G6PD deficiency. D. Anemia of chronic disease. E. Megaloblastic anemia due to folate deficiency. Correct answer, C. Hemolytic anemia due to G6PD deficiency. Explanation. TMPSMX can trigger hemolysis in patients with glucose 6-phosphate dehydrogenase, G6PD, deficiency, leading to hemolytic anemia. Why not the others? A. Iron deficiency anemia, presents with microcytic anemia, not hemolysis. B. Thalassemia minor, usually mild and chronic, not triggered by drugs. C. Hemolytic anemia due to G6PD deficiency, correct, TMPSMX is a known trigger. D. Anemia of chronic disease, normocytic and associated with chronic inflammation, not acute. E. Megaloblastic anemia due to folate deficiency, possible with TMPSMX over long term, but does not cause hemolysis.